Welcome back to the Deep Dive. We're here to break down those complex topics and hopefully make you feel way more prepared and, confident.
And today, we're tackling a big one in the IVF journey, the egg retrieval. You might hear it called follicular aspiration, which sounds kind of intense.
Yeah, definitely sounds a bit clinical,
Yeah.
but it's really that key step after all the stimulation meds, right?
Exactly. It's the moment everyone focuses on after weeks of injections and monitoring. So our goal today is to really walk you through what actually happens step by step.
We want to demystify it, basically, so you feel informed and maybe a little less anxious going in.
Precisely.
Okay, so let's dive in. I think the first thing people realize is that this isn't just any appointment. The timing seems incredibly crucial.
Oh, it's absolutely critical. It's all orchestrated around one final super important injection, the trigger shot.
Oh, yes, the trigger.
Usually that's HCG, sometimes Lupron. And its job is basically to copy the natural LH surge your body would normally have before ovulation.
So it's not about making follicles bigger at that point.
No, not bigger. It's about final maturation. It's telling the eggs inside those follicles, okay, time to get ready for fertilization.
Got it. And the timing after that shot is the really strict part.
Extremely strict. The retrieval itself has to happen like almost exactly 34 to 36 hours after you take that trigger shot.
Wow. What happens if the timing is off?
Well, if it's too early, the eggs might still be immature, meaning they can't be fertilized properly.
Okay.
But if you wait too long, you risk the body ovulating, naturally releasing the eggs before the doctor can even get to them.
That sounds like, yeah, a lot of pressure. So how do the doctors figure out the perfect moment to even give that trigger shot in the first place?
It comes down to all that monitoring you do leading up to it. We're talking daily, sometimes ultrasounds.
Right.
They're measuring the follicles, looking for them to hit that sweet spot, usually around 16 to 22 millimeters in size.
And blood tests, too.
Yep. Crucially, blood tests track hormone levels, especially estradiol. When the follicles look right on the ultrasound and the hormone levels match up, that's the green light for the trigger.
Okay, that makes sense. Such precision. So the trigger is given, that 36-hour clock starts ticking. Let's talk about the procedure day itself. I think a big worry is, will it hurt?
That's probably the number one question, and comfort is a huge priority. Most clinics use conscious sedation or IV sedation.
What does that actually feel like?
It's medication through an IV that makes you feel very relaxed, drowsy, kind of in a twilight state. You won't feel pain. And honestly, most people don't remember much, if anything, about the actual procedure.
It's pretty short, right?
Yeah, the retrieval itself usually only takes about 15 to 30 minutes. General anesthesia, where you're completely asleep, is much less common for this.
That's reassuring. But since there is sedation involved, there must be rules beforehand, like about eating or drinking.
Absolutely. Standard safety protocol. You'll need to fast no food or drink for usually 6 to 12 hours before the procedure.
Okay. Important to remember.
Definitely. And you're not alone during this. There's always a trained anesthesiologist or another medical professional right there, constantly monitoring your vital signs, heart rate, blood pressure, oxygen levels the whole time. Safety first.
Good. Okay, let's walk through the actual retrieval, the follicular aspiration part. How do they, get the eggs out?
It's all guided by ultrasound. The doctor uses a transvaginal ultrasound probe, similar to the ones used during monitoring scans.
So they can see everything clearly.
Exactly. It gives them a live picture of the ovaries and follicles. Then, using that image as a guide, a very thin needle is passed gently through the top of the vaginal wall, directly into the ovary, and then into each follicle.
Okay. Through the vaginal wall, not the abdomen.
Correct. Transvaginally. It's the most direct route.
Right. So the needle's in the follicle. Then what?
Then, gentle suction is applied through the needle. This aspirates or sucks out the fluid that's inside the follicle.
And the egg is in that fluid.
Yes. The egg itself is microscopic, totally invisible to the naked eye, but it comes out suspended in that follicular fluid. The doctor carefully drains each mature-looking follicle this way.
It sounds like a bit of a treasure hunt almost.
In a way, yeah. They're collecting that precious fluid.
Okay, so procedure's done. The fluid containing the potential eggs is collected. What happens, right that second?
It's an immediate handoff. That fluid goes straight into the embryology laboratory, which is usually right next door to the procedure room. Sometimes there's even a little pass-through window.
Wow, no time wasted.
None at all. The embryologist is literally waiting there, ready to go.
So what are they doing on their side?
Their first job is to carefully scan all that fluid under a high-powered microscope. They're looking for the eggs, isolating them, and counting them.
And they can tell you the count pretty quickly.
Often, yes. While you're still waking up in the recovery area, someone might come and tell you the initial number of eggs that were retrieved.
Okay, now here's the part I think catches people off guard. Let's say they tell you, great news, we got 10 eggs. Does that automatically mean 10 potential embryos?
This is such a crucial point to understand, and it's often where expectations need managing. That retrieve number is just the starting point.
Right.
Unfortunately, not every egg retrieved is necessarily mature or usable. On average, maybe only about 70% to 80% of the eggs collected are actually mature.
Mature meaning what?
Mature means it's reached the specific stage called MII metaphase 2. That's the biological stage where it's actually ready and capable of being fertilized by sperm.
I see. So out of those 10 eggs, you might realistically only have 7 or 8 that could even move on to the next step.
Exactly. So the focus shifts quickly from just quantity to the quality and maturity of those eggs.
And once they identify those mature MII eggs, that's when fertilization happens.
Correct. Those mature eggs are then prepared for fertilization. Depending on the situation, they'll either use conventional IVF, basically mixing the eggs and sperm together in a dish and letting fertilization happen sort of naturally.
Okay.
Or they might use ICSI,
I've had that acronym a lot. ICSI stands for.
intracytoplasmic sperm injection. It sounds complex, but it just means the embryologist selects a single healthy-looking sperm and injects it directly into the center of the mature egg.
Wow. When would they typically use ICSI instead of conventional?
Often if there are concerns about sperm quality or quantity, what's sometimes called male factor infertility, or if previous IVF attempts have poor fertilization, it kind of gives the sperm a direct path.
Gotcha. And after fertilization, embryos develop for a few days.
Right. The resulting embryos are cultured and monitored in the lab, and the embryo transfer back into the uterus usually happens 3 to 5 days after the retrieval.
Okay, one more thing before we move to recovery hormones. After the retrieval, does your body need extra support?
Oh, absolutely. During the retrieval, the cells within the follicles that normally produce progesterone are removed along with the fluid. Progesterone is essential for pregnancy.
Why is that?
It prepares and supports the uterine lining, making it receptive for an embryo to implant and grow. So patients almost always start taking supplemental progesterone, often along with estrogen, usually starting the day of the retrieval or the day after.
Makes sense. You need to maintain that supportive environment.
Exactly right.
All right, the technical stuff is done. Eggs are hopefully fertilizing in the lab. Let's talk recovery. What's the rest of that day like and the day after?
Well, the sedation wears off pretty quickly, usually within an hour or two in the recovery room, but you'll definitely feel groggy.
And the 24-hour rule?
Yep, absolutely firm rule. You must have someone drive you home. No driving, no operating heavy machinery, no major decisions for a full 24 hours after sedation.
Okay. And physically, what should someone expect to feel? Is it painful?
You should expect some discomfort, yeah. It's usually described as mild to moderate cramping, often like strong period pains, and bloating is really common.
Why the blood?
It's mostly from the ovaries being stimulated and enlarged from the medications, plus a bit from the procedure itself. You might also have some light spotting or a pinkish discharge for a day or two that's normal.
So how do you manage that cramping and discomfort?
Rest is key. Taking it easy, lots of hydration. And for pain relief, the go-to is usually acetaminophen, like Tylenol.
Not ibuprofen.
Generally, no. It's really important to avoid NSAIDs like ibuprofen, Advil, Motrin, aspirin, unless your doctor specifically says it's okay.
Why is that? I usually reach for ibuprofen.
NSAIDs can slightly increase the risk of bleeding or bruising, and since the procedure involves puncturing the ovaries, doctors usually prefer you stick with acetaminophen to be safe. Always follow your clinic's specific instructions, though.
Good tip. Okay, let's run through some quick do's and don'ts for those first 24, 48 hours. Lifestyle stuff.
Definitely do. Wear loose, comfy clothing. Think sweatpants, not tight jeans. Bloating is real.
Okay, comfy clothes. Got it.
Do. Rest. Avoid strenuous activity. Definitely no heavy lifting. Your body needs to recover.
What about showering? Baths?
Showers are fine, but generally it's recommended to avoid soaking in a bath, hot tub, or pool for a couple of days, mainly to reduce any small risk of infection.
Makes sense.
And diet-wise, hydration is super important. Drink plenty of fluids, water, maybe electrolyte drinks, and focus on high-fiber foods.
Why fiber specifically?
Well, the hormone medications, especially progesterone, plus the procedure itself, can sometimes lead to constipation. High fiber helps keep things moving without straining, which you want to avoid. High protein is good too.
Okay, so fluids, fiber, protein. What to avoid?
Definitely avoid alcohol while you're recovering. Limit excessive caffeine.
And the sensitive question. Intercourse.
Yeah, generally advised to hold off on intercourse until your doctor gives you the green light, usually for a week or two. It's partly for infection risk, partly comfort, and also to avoid any risk, however small, of ovarian torsion where an enlarged ovary twists.
Okay, that's a really practical checklist. Now, the crucial safety part. When does that normal cramping or bloating become something you need to call the doctor about immediately?
This is super important. While mild to moderate discomfort is expected, we always watch out for signs of ovarian hyperstimulation syndrome, or OHSS. It's rare, especially with modern protocols, but it can be serious.
What are the warning signs of OHSS or other problems?
You need to call your clinic right away if you experience severe or worsening abdominal pain that Tylenol doesn't touch, or heavy vaginal bleeding, meaning you're soaking through a pad in an hour.
Okay, severe pain, heavy bleeding. Anything else?
Yes. A fever or chills, significant difficulty urinating, or really severe bloating that comes on quickly, especially if it's paired with rapid weight gain or shortness of breath. Don't hesitate to call if something feels really wrong.
That's vital information. Okay, so just to quickly recap this whole deep dive, it starts with that critical trigger shot timing, 36 hours before. The procedure itself is quick, usually under comfortable conscious sedation. The collected fluid goes immediately to the lab where embryologists count and assess the eggs. And recovery is all about rest, hydration, managing mild discomfort with Tylenol, and watching for those important red flags.
You summed it up perfectly. And maybe one final thought to leave you with, something that often eases minds.
Yeah.
Doing an IVF egg retrieval doesn't typically impact your long-term fertility or use up your eggs faster. Remember, your ovaries contain thousands upon thousands of eggs. Retrieving 10 or 15 in one cycle is a tiny fraction and doesn't significantly deplete that large reserve.
That's actually really comforting to know. It puts the whole process into a better perspective.
We hope so. Now, just the important reminder. Everything we've discussed today is for informational and educational purposes only.
Absolutely. This does not constitute professional medical advice. You should always consult directly with your own doctor or healthcare provider for any medical advice specific to you.
Couldn't agree more.
And if you're looking for more comprehensive information on the entire IVF process, you can find great resources over at ivfforme.com.
That's ivfforme.com.
We really hope this breakdown of the egg retrieval has been helpful and leaves you feeling more empowered on your journey.
Thanks for joining us on the deep dive. We'll catch you next time.